In the first days of life, a neonate's vulnerability is measured in hours. A ticking clock begins the moment of delivery, defining an immediate and narrow window for clinical intervention. The stakes within this window are absolute. Neonatal sepsis accounts for approximately 25% of all neonatal deaths worldwide. Yet this immense mortality rate masks a clinical paradox. The physical presentation of a newborn experiencing a massive systemic infection is incredibly subtle. The overt distress signals seen in older patients are largely absent. Looking at the global epidemiology data, the threat landscape is actively evolving. There is a documented pathogen shift occurring, moving away from the traditional Western dominance of Group B Streptococcus toward a high burden of gram-negative bacteria in Southeast Asia. Because the physical symptoms are so well hidden, waiting for clear signs of illness is a fatal strategy. A physician's primary defense relies on a rapid, algorithmic interpretation of timelines and laboratory data. The foundation of this clinical algorithm is a strict temporal bifurcation. The entire diagnostic approach hinges on exactly when the symptoms appear, split by a threshold of 72 hours. Infections that present within the first 72 hours of birth are classified strictly as early-onset sepsis, or EOS. EOS is driven exclusively by vertical transmission. The pathogen passes directly from the maternal genital tract to the infant during the birthing process. Conversely, symptoms that emerge after that initial 72-hour window and up to 28 days of life are categorized as late-onset sepsis, or LOS. LOS is not acquired from the mother. It is driven entirely by horizontal transmission, meaning the neonate contracts the pathogen from the surrounding hospital or NICU environment. This temporal dividing line immediately dictates the clinician's next moves. Knowing when the infection started tells them exactly which transmission route occurred, which specific pathogens to hunt, and which empiric antibiotics to prepare. This matrix outlines early warning signs for early-onset sepsis. Clinicians map specific maternal risk factors before the baby is symptomatic. Critical indicators include a prolonged rupture of membranes over 18 hours and prematurity under 37 weeks, alongside signs of chorioamnionitis or maternal GBS colonization. If the neonate clears that 72-hour window, the threat matrix shifts entirely to the environment. For late-onset sepsis, prematurity and low birth weight exponentially increase the neonate's vulnerability to external pathogens. The risks are now tied to the realities of a crowded NICU, poor hand hygiene, overcrowded wards, and the necessity of invasive procedures. Prolonged parenteral nutrition, specifically the administration of intravenous lipids, serves as a major vector for LOS pathogens to enter the bloodstream. Tracking whether a neonate's primary exposure was a complicated womb or an intensive care ward is the first step in preempting sepsis. This diagram details the sick neonate. Clinicians evaluating newborns must discard adult criteria. Instead of a mounting fever, the primary warning sign is temperature instability, specifically hypothermia. Overt distress is replaced by subtle behavioral cues. A poor cry and refusal to feed are often the only initial symptoms. Respiratory and cardiovascular manifestations present as unexplained apnea, grunting, tachypnea, and delayed capillary refill indicating poor perfusion.
Severe decompensation reveals itself through late-stage indicators: severe gastrointestinal distension, a precursor to necrotizing enterocolitis, and sclerema, a hardening of the subcutaneous fat. Because the infant's body shuts down quietly rather than fighting loudly, physical observation is never enough. Even the slightest behavioral deviation must trigger an immediate laboratory investigation. These hematological criteria graphs map out the sepsis screen, the definitive arbiter of truth when clinical signs remain ambiguous. The first specific criteria is leukopenia, defined strictly by an absolute neutrophil count dropping below 1,500 per cubic millimeter. Next is the immature to total neutrophil ratio. A value greater than 0.2 indicates the bone marrow is desperately releasing premature cells to fight an overwhelming infection. The erythrocyte sedimentation rate requirement tracks a micro-ESR rising greater than 15 millimeters in the first hour. C-reactive protein operates on a vital kinetic timeline. CRP only begins to rise at 6 to 8 hours post-infection, making the exact timing of the blood draw critical to avoid a false negative. While hematology builds the case, microbiology and cultures remain the absolute gold standard. A valid neonatal blood culture requires a strict volume of 0.5 to 1.0 milliliters. A lumbar puncture is mandatory to definitively rule out asymptomatic meningitis, which is completely invisible to physical examination. In neonatal medicine, hard data outranks clinical intuition. Once these specific hematological and microbiological thresholds are crossed, the physician is locked into an aggressive treatment pathway. Once the sepsis screen confirms the suspicion of infection, clinicians do not improvise. They initiate this rigid, stepwise algorithm designed to rapidly reverse septic shock. Step 1 is rapid fluid resuscitation. Clinicians administer 10 to 20 milliliters per kilogram of normal saline to immediately restore circulating blood volume. Step 2. If fluids fail to stabilize the neonate's hemodynamics, pharmacological support escalates to inotropes like dopamine or dobutamine. Step 3 targets instances of suspected cold shock and severe cardiovascular insufficiency with the administration of epinephrine. Step 4 addresses persistent refractory shock. If the system remains unresponsive due to suspected adrenal insufficiency, the final administration is hydrocortisone. This algorithm forms an unbroken chain. Each failure of the infant's body to respond dictates an immediate escalation to the next pharmacological tier to maintain vital functions. Because the mortality rate spikes so dramatically once the shock cascade begins, true intervention must occur at the point of transmission. To prevent early-onset sepsis, mothers who are GBS positive or categorized as high risk receive critical intrapartum antibiotic prophylaxis, or IAP. To prevent late-onset sepsis within the NICU, strict hand hygiene remains the single most important factor in stopping horizontal transmission. For neonates who survive the infection, the neurotoxic effects of both the disease and the treatments require rigorous, long-term serial monitoring of hearing and developmental milestones. Neonatal sepsis demands a flawless clinical response. The 72-hour clock dictates the enemy, subtle hypothermia masks the danger, and survival relies entirely on the rapid, unyielding execution of the diagnostic screen and the shock algorithm.